TopMedTalk.
Well, hello, I'm Desiree Chappell, and this is TopMedTalk. We are live from the European Anesthesiology Congress, EUROANAESthesia 2019 here in Vienna, Austria. And I'm joined by Editor-in-Chief of TopMedTalk, Monty Mythen. Monty, how are you?
Flagging.
Yeah, you're working hard today, aren't you?
No, I'm great. I'm doing really well.
I don't know exactly if I know what flagging means.
How do I look?
So you look bright, cheery, and fabulous.
I'm bright, cheery, and fabulous. That's what flagging means. Bright, cheery, and fabulous.
You've been busy today, though.
Yeah, it's good. We had apart from starting here early, getting the recordings done, we had a interesting, exciting lunchtime session sponsored by Edwards Life Sciences, talking about blood pressure hemodynamics and some new technology, which I'm sure we'll come back to in a moment. Yeah,
definitely. So I thought that was great. And we actually have one of the presenters that was there with you as well. Join us, Thomas Scheeren, who is a friend of the TopMedTalk family.
Yeah, I've been here before, actually, so it was fun, and I'm looking forward to it.
Good. Well, Thomas, for everyone that has not heard the previous podcast, can you tell us a little bit about yourself, where you're from, and what you're doing right now?
Right. So I'm a professor of anesthesia in Groningen, which is in the north of the Netherlands. Since 2010, I'm working there. Before that, I have been working for 17 years in a city called Düsseldorf, and for 5 years as a professor in Rostock, which is former Eastern Germany, before I came to the Netherlands in 2010.
Okay. And what is your primary focus in research and practice there?
So my research activities are most in hemodynamic monitoring and its association with patient outcome. Clinically, I'm working mostly in cardiac surgery, so cardiac anesthesia, but I also do non-cardiac lists once or twice a month.
Okay. Well, the presentation that you gave today was what are the physiological mechanisms underlying hypotension. So the hypotension story is that we've been talking a lot on TopMedTalk, and the impact of that on outcomes is not something that is clear. But what is the hypotension story from your perspective and your experience right now?
So in the meantime, it's common knowledge that hypotension is a bad thing, so it occurs quite frequently and it causes harm. We are not quite sure what the level of hypotension is or what the exact definition of hypotension is that we are talking about. But if the blood pressure is too low for the particular patients, whatever the threshold would be, harm is accumulating, and we are particularly worried about myocardial injury, renal injury, probably also stroke, and probably even mortality. There's a lot of retrospective data showing that there is an association of these low blood pressures with any of these outcomes. So this is, of course, not a causal relation, but it's a very strong signal from epidemiology that there might be causal relation.
Yeah, it's true. Well, Monty, you were chairing the session today. There was some really good discussion.
Great, lots of questions came in, and some of the recurring themes that are asked about quite often. But in the session, Thomas, you presented data from a publication, a two-center publication, which was published relatively recently. In which journal?
It was published in Anesthesia Analgesia recently, so it's available online right now. It's not at a printed issue at this moment.
So e-published, and that's between yourselves and York with Dr. Simon Davis,
yes,
who we've had on TopMedTalk relatively recently. Yeah. And I think that I think one of the reasons you did it, you said, is that your centres that are very proactive in hemodynamic management, and therefore your expectation would be that maybe you wouldn't have that much hypotension, but you found quite a lot, I believe.
Yeah, so both of our centers actually do goal-directed therapy in our high-risk surgical patients. So this means that we optimize our patients in terms of blood volume and flow. This is a primary goal. So we were expecting that these hypotension incidences that we just talked about would be less because we do care really good for our patients. So this was the hypothesis, and we were quite surprised to see that this is actually not the case. So even preventing or optimizing the blood pressure, the blood flow and the volume does not prevent hypotension from occurring. So we found incidences of 87% of our patients had a hypotensive event, which was defined as a mean arterial pressure below 65 for more than 1 minute. 87% of the patients, so almost everyone had at least one episode of hypotension.
Did you say I'm sorry to interrupt, for 1 minute? Is that right?
At least 1 minute.
At least 1 minute, okay. Did they look at what the average time of the length of the hypotension was?
Yes, we did look at the number of incidences, which was a median of 4 episodes. The median duration for each event was 2 minutes. And the cumulative duration of those was something about 9 minutes, between 9 and 11 minutes. So 6%, if you relate this to the case time, 6% of the operation the patient spent in hypotension.
Wow. So that was
quite surprising.
And another key component of the paper was comparing it to all the other things that people thought would predict hypotension. One of them, this novel indicator, which we talked a bit about before.
Yes.
But also all the other things that people might think, the rate of change in blood pressure or the magnitude of change in blood pressure or stroke volume variation would predict the blood pressure drops.
Yeah, interesting thing is actually when we published this paper, we first sent it to one other journal, a major anesthesia journal, and I don't tell you which one it is, but the reviewers just said this same thing. They said, we as experienced anesthetists, we can predict if blood pressure is going to drop by just looking at the blood pressure. And we could very nicely show in our paper that the changes in mean arterial pressure 5 or 10 or 15 minutes before the hypotension occurs do not predict the hypotensive event. It's just like flipping the coin if you look at these receiver operating characteristics curve of the prediction of hypotension.
Oh, wow. Oh, I'm sorry.
No, please carry on.
No, so one of the things that I find interesting is that what was the reaction? I mean, this is kind of taking it down a little bit level from the research, but what was the reaction like in your department whenever they started seeing this? I mean, they had to believe what you were finding, but did it start immediately changing practice or?
Not yet, because we were all blinded. So we for this study we had no availability. We had this HPI index not available to clinicians, and even now we are doing a study, a 3-phase study. So the first phase was this observational part, just looking at the incidence of hypertension. In the second phase, we will try to prevent hypotension with the usual hemodynamic variables that we have available.
Gotcha.
And only in the third phase of the study, which will probably begin in Q3 or Q4 of this year, later on this year, and then we will have the HPI available to clinicians, and we will look at the behavior change of our colleagues when they have this variable available. Will they give more or earlier fluids or vasopressors? But I cannot tell you at this moment.
So we should add probably, Desiree, for our regular listeners who say, hang on, we've spoken quite a lot about this before recently, but we know we've got a whole load of new listeners.
Yeah.
So for the new listeners, if you go into our search engine on the website or on the app, and you either put in blood pressure or HPI or hypotension, you'll get a raft of the growing catalogue of where we go into these factors in more or less detail over time, of which Thomas has generously contributed to that. So we'll continue down this path for a little, but those who want to go to the back catalogue, that's the way to search it, is the best way to get there.
You can find a lot of information on there. So, Thomas, switching gears just a little bit, unless you had any other questions on that.
Good.
So, during the presentation, you were saying I get the same questions kind of over and over again. What are some of the questions that you get most about, what you're doing right now?
So the question is, what will change your clinical practice most? And these are, in my opinion, 2 things. So we can, for the first time, predict something from occurring. So we don't have to wait until it actually occurs. So we don't have to practice reactive medicine, waiting until the hypotension occurs and then treat it, and then think about what the mechanism and then treat it, which causes a delay.
Yeah.
And if we believe the association data that are available, every minute of hypotension accumulates in creating harm.
Yeah.
So we should keep the hypotension as short as possible or even prevent it. This is the first thing. So from reactive to a proactive measurement. So by using this new index, we might even be able to prevent completely the occurrence of hypotension. And this has to be shown that this has an impact on the patient outcome, but it's very intriguing that it will be. And the second thing is the way that we treat the hypertension, because hypertension is not the one hypertensive event is not the same as the other, and so we have to think about what is the reason. In previous years, we all the hypertensive events were treated the same. We gave a liter of fluid first, and if this does not work, we give a vasopressor, and that's it. Now we can, with a secondary screen of this monitor, which comes along with the HPI, will tell us what is the problem. Is it a contractility problem of the heart? Is it a vasotonus problem that we can give a vasopressor? Is it a volume problem? And the contractility thing, this is new because we didn't have this information before. And now we can see that quite a lot of patients are actually having contractility problems of their heart, even patients which have no heart disease previously. So our anesthetics obviously do something to the contractility of the heart. And if we see that, we can specifically treat the hypertension caused by this origin. So the use of inotropes has dramatically increased in our department because we now are aware of this problem, and as we didn't have an inotrope in the room, in the
that's what I was just going to ask.
Yes, we now realize that this is in a significant number of patients actually needed. So we now keep it available and make it available to the clinicians to make use of it. Yeah,
so it's taking it down. So like people will bring in like a dobutamine. I know that was mentioned.
This is the one that we use.
Right, and that's probably common, right, in the suites.
Yeah. I know in the UK you have dopexamine. We don't have this in our country.
Yeah.
But I think it's not the issue of which drug you use. It's the type of drugs that you use.
Right. And then you're starting an infusion of the dobutamine, I would assume. Are you doing like boluses of milrinone or anything like that? I know in the US that some people will say that'll be their first-line drug, which may or may not be the right answer. But
I'm not a friend of bolus injections of vasoactive drugs at all because we have abilities to give it continuously, and this is a smoother way to avoid these peaks, because also hypertensive peaks might cause harm to the patient. So we would like to avoid this. So I always give it continuously. And regarding your second part of the question, milrinone, I'm doing a lot of cardiac anesthesia, as I said, and sometimes I use milrinone in the cardiac patients, especially when it's a right heart problem or pulmonary hypertension problem. In those patients, I would prefer milrinone, but in the non-cardiacs, I almost never use milrinone.
And you said all of the vasopressors are infused, and I know I'm kind of going down a rabbit hole a little bit, but I get this question a lot whenever I talk, at least in the U.S., and a lot of people are still bolusing with like a neosynephrine or ephedrine or something like that. I mean, is that typical practice in not just for you, but like in your department and in your culture?
Unfortunately, it is still clinical practice, and then you see these up and downs in the blood pressure if you look at it. I wonder if this is a good thing. So, me personally, I don't like this. I would not prefer this. But at this moment, I don't have hard data to show that this is not really inferior.
Yeah, it's interesting. I've just personally changed my practice since I've been talking to everybody, and to avoid the spikes and embolusing. So I go immediately to an infusion now, and it's just. You do notice that it's different, but it's not based in science. I just thought that was interesting there.
Another practical question related to that. Is it dilute and peripheral? Is it a 50 ml syringe? Is it the same mix as cardiac?
This is a good question because in most of those patients we don't have a central line. Yeah. So we use a lower concentration. We use 1 milligram in 50 ml. We call this norepinephrine light.
Yes.
For those patients, if they should go to the ICU afterwards, we would insert a central line and change to a higher concentration, for example, 5 or 10 milligrams in 50 ml.
And your dobutamine, more comfortable giving that peripherally?
Yes.
And in everything that you do, I mean, for me, in my own personal experience, it seems like, we're finished with the case, everything, they start waking up, we get to turn everything off, and everybody's happy again. Are you still finding that's your experience? Like, that now that you've started more infusions and you started people on dobutamine, are you sending more people to the ICU, or how's that kind of change things? Does that make sense?
Yes, it makes sense, and we had a lot of discussions with our ICU, which is, by the way, a separate department, and the first reaction when we bring a patient, the blood pressure is low, they give literal fluids. Yeah. So all that, the efforts that we did intraoperatively to limit the amount of fluids by using goal-directed is a way within 15 minutes after admission to the ICU, because the blood pressure is low. Yeah. So it needs a lot of education to keep this kind of thinking into the brains of the colleagues, to think about to continue this efforts that we do at least until the first 24 hours after surgery. That would be ideal. Yeah. We're working on that.
I know. It's the education piece that always comes back. Comes back down to that.
And convincing them that you should continue using one of these, even if it's a non-calibrated cardiac output device. Our intensivists say, the cardiac output measurement is not very precise if you use one of these uncalibrated arterial waveform-based monitoring, for example. But my answer would be, I'm not interested if the cardiac output is 3.8 or 4.2 liters per minute. I would like to know if it changes after my intervention, and these changes, the tracking of changes, this is perfectly tracked by all of these monitors we are now talking about. So this is a misperception of the intensivist colleagues. Yeah. We are not interested in the absolute value, very precise value of cardiac output, which we would need to have a Swan-Ganz catheter, for example, which we don't use anymore. No, we are just interested in the hemodynamic picture and see if the interventions that we choose are effective in terms of increasing flow.
It's a frequently missed point, not just in intensive. I mean, that's in the OR. I mean, I'm one of those people that I've tried to get a whole department, to use advanced hemodynamic monitoring or whatever the new, tool is that we're using, and that it's not always absolute all the time. You have to look, at the trends and. So we're probably going to wrap up soon. Monty, did you have any other questions? I have one more.
I'm good at the moment.
You're good. Thomas, and I know you've said this before, but just to hear it again. So you started out as pretty skeptical about some of this technology, and you had been familiar with goal-directed therapy, for a while, right? And that was something you believed in. So your skepticism, how did that really change for you? Like, when did that change? What was that?
So wrapping up my skepticism, it was the first thing was that I was thought we are taking best care of our patient by doing goal-directed therapy. Mm-hmm. So hypotension is not a problem in our patients. It is, as it turned out to be. The second misconception was, like these reviewers from our paper, I always thought, I'm doing for anesthesia for more than 20 years. I can see when a patient is getting into hypotension just by looking at blood pressure or the hemodynamic picture on my monitor. I don't need this fancy additional number. But I was convinced by looking at the data and these ROC predicting analytic curves, which really convinced me that it's performing much better. And it's logical. If you know, maybe for a wrap-up, it's too long to explain how this variable is working. But if you consider that it's consisting of many factors going into this HPI predictive index, it must perform better than only looking at one variable, like blood pressure or cardiac output or heart rate. Of course, a combination of many factors should perform better than only one single variable.
That's a really, really good point. I can continue to talk to you. There's a ton of stuff because we could go down the AI hole completely and get into that. But I know we're strapped for time, and I just want to say thank you so much for again sitting down with us again on TopMedTalk. We love to hear what you have to say, and I think your story is great. And a lot of us in the OR and in anesthesia in perioperative medicine can really relate to what your what your experience has been. So
keep
I
up the
appreciate
good work.
that. Yeah, absolutely.
Thank you.
Looking forward to hear what's coming.
Yeah. Thank you very much. It was a pleasure, and I'm looking forward to the next time. Maybe.
Yeah, absolutely.
Thank you.
Love it. All right.
Take care.
Thank you so much. Cheers.
TopMedTalk.
Nick Majerison here. Thanks for listening to TopMedTalk. Now, before we let you go, it's important that we remind you to subscribe to TopMedTalk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com and click on the section marked email updates. Finally, TopMedTalk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on TopMedTalk. That's ebpom.org/meetings.